Hi, welcome back to the UBC Biophysics and Medical Physics Student Society YouTube channel. Today, by popular request, we're going to hear from a medical physicist. So we'd like to introduce Dr. Samantha Lloyd, a senior medical physicist at BC Cancer Vancouver.
Thank you so much for joining us. Would you mind going over a little bit of who you are and what you do?
Sure thing. My name is Samantha Lloyd. I'm a medical physicist at BC Cancer Vancouver. I'm also a clinical assistant professor within the Department of Surgery in the Faculty of Medicine. I had to think about that. And I am a clinician scientist, I guess. So 80% clinical and 20% research, teaching, administrative, etc.
That's awesome. And how did you get here? Do you want to talk a little bit about your path?
I love this story. I started out as an undergrad at TRU, and I didn't know that medical physics was a thing. I was part of the co-op program, and I landed at Triumph, where they were still treating proton therapy on the proton line for ocular melanomas only, using this like cool 6-DOF chair. And I happened to be working with Ewer Blackmore, who was running the program at the time, and I got to just sit and watch these patients come in for their planning sessions for their radiation for ocular melanoma. And I thought, this is the coolest, craziest thing that I've ever seen or done, and I want to be part of it. And then what was extra interesting is that the lady who was coming for treatment was from my hometown in Prince George, and she knew who my mom was. So I ended up sitting and talking with her about proton therapy and the physics of it and bright peaks, and she was really interested, and I was really interested to share that with her, and that really sealed the deal. I thought, this is the best way to use physics to help people.
That's really cool. And that doesn't even exist anymore, so kind of a unique opportunity.
Yeah. And it was a really cool experience to get to meet some of my current coworkers in that setting without knowing that they would be my coworkers in the future. And so it's cute to think back like, oh yeah, I remember you 15 years ago when you were very, very young.
That's awesome. Okay, and then from like the seed of, wow, this is so cool, how do you grow that into a career?
Yeah, so the most straightforward route for a medical physicist to become a radiation therapy physicist like me is to start in a CAMPEP accredited graduate program. And the CAMPEP accreditation is important because that makes you eligible to do a CAMPEP accredited residency, which makes you eligible to sit your certification exams, either the American Board of Radiology in the US, or in Canada, it's the Canadian College of Physicists in Medicine, which is a like full day written exam followed by a 3-hour oral exam if you pass. So like a little bit stressful, but it all starts with finding a CAMPEP accredited graduate program and a research project that you're interested in.
Awesome. How important would you say is like the research project versus getting the CAMPEP accreditation? Like how does that all line up?
Yeah, so the CAMPEP accreditation goes over, it evaluates your coursework alone and not the research project that you're doing. So it's essential that a medical physicist in a CAMPEP program be exposed to radiation physics, imaging physics, radiation biology, anatomy, and then also a certain degree of clinical shadowing within a radiation therapy department. And so as long as you're checking all those boxes, the research that you're doing in addition to that is kind of inconsequential, but super important. Because if you're signing up for a PhD, and I tell this to everyone I talk to who's thinking about a medical physics PhD, it's more important that your project is something that you're passionate about and excited about than maybe directly related to radiation therapy, if that's your goal, because you're going to be living with this project for 3 to 5 years. It's going to become your entire life. And if you are already kind of lukewarm on it at the beginning, you are going to hate it by the end. So you want to be excited about it in the beginning, because I think everyone's sick of their PhD by the end of their PhD. But if you start out really passionate about it, then you're going to be better off getting to the end. There are like so many things I want to say in here. The other piece is that lots of medical physicists come into the field with like diverse backgrounds, which is amazing because we need folks who are great at MR imaging. We need folks who have solid state backgrounds and can do computational imaging and all of these subdisciplines, because we come together, and even though we're not all experts at all the things, we can encompass everything, and that's what makes a comprehensive therapy program that can do lots of really cool things.
What would you say are like maybe the top 5 or 6 programs that benefit you when you maybe go into graduate program in physics?
Well, I mean, I think the most common route would be through imaging physics or through like a radiation therapy focused research project. So like I have a grad student working with me on radiomics related to outcomes prediction in lung cancer following stereotactic ablative radiation therapy, or SABR, or SBRT, depending on like what part of the world you're in. And so her research is very quantitative, very imaging based, but like rooted in radiation therapy. I'm trying to think of some of the other projects. I know there are other PhD students who've done lots of work in the dosimetry of like a skin dosimetry, which is really difficult to do because like the first 5 millimeters of any surface, it's really difficult to model the electron scatter in that area. So like dose deposition is very difficult. So research into that area is really exciting and important, but not something that we might necessarily be researching on a day-to-day basis in my field. But once it's established, we would absolutely use it. Imaging, like Corey Lull's group in MR at UBC and like other imaging groups is like another very common pathway. So lots of like I didn't do imaging, so like all the flavors are probably the same bucket to me, but there's like lots of really interesting stuff happening in that field, and that translates like back into RT radiation therapy if that's what you're interested in. And it's that CAMPEP accreditation that makes that possible, right? You've like covered all of the basics in the coursework, so you're equipped to jump into a therapy setting for training, if that's what you want to do. I would say like the third most common route involves a certificate. So imagine you do your whole graduate degree and you didn't know about medical physics, and then suddenly somebody tells you about it. And you're like, oh, this sounds really exciting. I would love a job. And you have a PhD in a related sort of physicsy field. You can take a certificate program, which is 8 months of just that CAMPEP coursework. There's one offered at UVic, and there's one offered, I think, at U of C, and others elsewhere in Canada. And that fulfills that CAMPEP accreditation and gets you into a residency. And I would say this like next most common subdiscipline is astronomy.
I wouldn't expect that.
You wouldn't expect that, except that astronomy, I think astronomy as a graduate student is really, really exciting and interesting. And, you know, like you have all of this great observational data and you're building all these models, and then you get to the end and like, what is a job as an astronomer? I think the job market is very difficult. And if you're looking for something with like a bit more job security, the medical physics kind of makes sense. And it is like very applied. So it's less building models and testing them and like sort of high level and more individually directed. So like two different scales of thinking, I think, but the same problem solving skill set.
Yeah. So you'd say like physics is a good foundation to,
Yes.
you know, build all those other skills.
Yeah. And I think like the physics math sort of backbone, like that undergraduate physics degree is what starts you on that path. I would have to look more carefully at like the admission requirements for a particular graduate program, but I think I was surprised to see that like biophysics is like separate at UBC, but I'm sure that that also feeds into a CAMPEP accredited program. So I think all of the sub-physicses.
You mentioned like the job security and the job market.
Mm-hmm.
Could you comment on, you know, what that looks like for you? Maybe the split between the different things you do?
Yeah, so in terms of the market, it's kind of an exciting, you've caught me on a very exciting day and an exciting week, because there have been government announcements that they're putting freezes on hiring at like all parts of PHSA that are non-contract, which is like essentially if you're not a doctor or unionized, so a nurse or a radiation therapist, there's like no hiring right now, which is opposite of the signaling that we've been getting that they're going to be over hiring all across Canada in the next 5 years, because they'll be opening all sorts of new cancer clinics across Canada in the next 5 years. We know from the health human resource modeling that the bolus of retirements that are coming from all of the baby boomers will not be backfilled by the number of trainees that we have coming through. So we're going to be in a health human resource crunch, including in medical physics, and we won't have enough physicists to go around. I think we're already seeing that in rural centers where they're taking years to recruit for a single position. So if you get through the graduate program and the CAMPEP residency and you are certified, there will be a job. Like it hasn't always been like that. When I came out of my residency, it took a little while for me to shop around to get my first position, but I don't think that will be the case over the next decade, and maybe going ahead like further out. So all of the restructuring and like the political kind of spiciness aside, I think long term across Canada, the job prospects are excellent. They've never been better. So then the second part of the question was, what am I doing day to day? I was thinking about this a lot today, and a big part of my job is evaluating the safety profile of a program or a treatment or a scenario or a technology, and ensuring that the way that we're using it or planning it is safe ultimately for the patient and for the staff providing the care. So we're really these like safety gatekeepers, and that might look like plan review. It might look like chart checks. It might look like a big checklist of things that we make sure, like, okay, the door is closed and the lights are on and the chime has chimed. Those sorts of checklists. Or it might look like, what are the functional limitations of this imaging tool? And if my patient is breathing at a respiration rate of like 4 seconds per cycle, am I going to capture every part of the breathing motion? And if I don't capture every part of the breathing motion, am I going to miss the target based on that image? So understanding the limits of technology, where things can become unsafe. Today, my day looked like helping with an adaptive plan for a patient who requires some problem solving. So she started out with her course of radiation treatment and it's not working for her. So we needed to make a change partway through. And so I was consulting on that for a big chunk of my day. I had a check-in meeting with a group of physicians, therapists, and physicists about gynecological practice in general. And we talked about the cases that are coming up next week in our brachytherapy program. And would you like to use more needles? Where would we put the needles? How can we better approach this dosimetric problem? We talked about, I had an impromptu meeting with some colleagues about fallback planning. So we're bringing in new technology. It's called a rad-exact, and it's like a helical radiation delivery technique. But if that machine goes down, we only have one. So the patients who are supposed to be treated on that unit have nowhere to go elsewhere in the building. So what is the fallback planning strategy? So we were having conversations about that. So sometimes it can be really focused, like I'm doing this one measurement and I'm comparing it against my expectation, or sometimes it can be like very broad thinking, like in general, what would make this a more safe procedure?
That's really cool.
It's a lot of different things.
Yeah.
Every day is different, and in that way, they're all the same.
I guess that's one way of looking at it. Yeah. What would you say are the skills that help you succeed in such a diverse, chaotic environment? I guess.
Not that I'm demonstrating it well today, but communication is really important. I think being able to communicate complex ideas to people of varying backgrounds, and not that you're dumbing anything down, because everybody is like very highly trained in our discipline, but they're very highly trained in anatomy, physiology, biology, in patient communication. So being able to take complex, elaborate ideas and communicate the important parts and emphasize the parts that you're trying to emphasize, to be like, this is the safety concern and this is why and this is what we need to do. That's really, really important. Be like teamwork, being able to work on multidisciplinary teams is essential. Honesty and like ethics is something that I don't think about, I think because it's sort of implicit, but the ability to very quickly identify, I've made a mistake, this isn't right, and not having any hesitation to highlight your errors for the sake of patient safety, which feels very abstract but is essential. And I think that like ethical honesty, like forthcomingness, comes across really well. You get that vibe from a person when you're interviewing them for like a residency position, for example. So like you can't bring any ego to the table in our job. And then like attention to detail is important. The ability to like boil something down to first principles. It's really useful if you can like make quick estimations based on the things you know. That can be really helpful. I could go on forever, but it takes lots of different physicists on the team to make the team work really well. So not every physicist is going to have like every property of a perfect medical physicist, but together we make the composite, and we play off each other's skills.
That's really awesome. So good teamwork too, then, I imagine.
Yes. Yeah.
How much of your responsibilities are teaching related?
Yeah. So there's this magic 80-20 split that some physicists in the US like can boast about, and it looks like 4 days of clinical work and 1 day of like non-clinical work, and that could be research, teaching, administrative work, like volunteerism with professional organizations, whatever. And I would love that. In reality, in the Canadian context, we are all clinical all day long, and if you can carve out time for the other things, then good for you. Within our department, we are supported to participate in teaching activities because that's a super important part of raising and bringing up the next generation of medical physicists, right? I talked about this HHR crisis. This starts at Physics 404 at UBC, where we're letting undergraduates know, like, hey, this is the thing you can do. You should talk to me later, and we'll have you over to the clinic. So we're supported in building that in, but it kind of has to go wherever we can fit it. Most places that you go will also allow for like cute little perks like a sabbatical. So if I had a big research project and some funding to do it, I could apply for 3 to 6 months of protection from clinical work, which is tough because then that clinical work gets put onto my colleagues. But then when they go on their research sabbatical, I'll do the same for them. And that's the same that you would see for like a physician. A physician would get the same sort of benefit.
How much of your like research gets to be really experimental, or is it very like clinical application focused?
Yeah, mine is very application focused, but that doesn't mean that that's true for everyone. I have a girlfriend who's finishing her residency at the University of Washington, and she does a lot of like benchtop, like mouse model, like preclinical work, and so hers is very experimental. Whereas I am more on the applications, like how effective is this for this cohort of patients, and like should we be using surface guidance instead of tattoos to set up our breast patients, like those sorts of questions. And that's just me and my preference, but someone who's got like a strong experimental background who can carve out that time and maybe like get a little funding. I can't think of a department that wouldn't support that activity.
Oh, that's really cool.
Yeah. The other thing that I wanted, I'll mention now that I'm thinking of it, is that I am in like a very large center with access to a lot of things, which means that I don't necessarily get to do everything. I don't get to do both motion management and daily adaptation. Like there's a limit to my capacity, obviously. But if you go all the way to the other end of the scale, you could have like a whole clinic with one Linac, where the physicists there, the 2 physicists there are doing everything. And so if that's more your vibe, that you want to have a taste of absolutely everything, that's absolutely on the table as well. It probably means that you don't get to go as deep into any one thing, but it does mean that you're popping between different problems like more frequently, and that is attractive to some people. It's actually attractive to me as well. I think both are cool, but this discipline is so great in that you basically can have whatever configuration that you want, as long as you're willing to move for it.
Yeah, I guess there's a lot of flexibility depending on where you go.
Yeah, there are only 6 centers there's 6 cities in BC that currently have radiation therapy facilities. That will expand to include Kamloops and Nanaimo in the next 5-ish years, and then expansions to Burnaby, Cloverdale, that's like Lower Mainland-ish. And that's like the 10-year cancer plan. And who knows what the 20-year cancer plan will look like. I mean, maybe that expansion goes even further to Campbell River or Fort St. John.
Do you think it will keep growing like that?
It depends on the population and the cancer burden. If somebody comes up with a immunotherapy drug that cures all cancers tomorrow, then we're going to be only treating functional things, and then maybe we're only treating radiation therapy in Vancouver, and that would be great too. I don't know where we'd all go. And I feel like I would have heard of it if it were coming, but maybe it'll happen. And then cancer is cured. That would be great.
Well, the good news is physics is a strong foundation for anything.
It is. It is. You can do basically anything and be in finance. So that's my backup plan.
Oh, that's awesome. What would you say are some good, I don't know, first steps to like getting set up for that? Maybe like co-op or classes? What kind of things would you recommend?
I found co-op really useful. I came from a small university, no honors degree, like that wasn't even an option. And without co-op, I don't think I would have gotten into a graduate program. I mean, at an institution like UBC, you've got so many options to connect with researchers, Physics 404. I'm a teacher in that class, at least next year. And it's, I think it's a really great overview of all of the subdisciplines. And I mean, I've mentioned MR and imaging, I've mentioned radiation therapy, but nuclear medicine is also blowing up right now. And so Carlos and Armand and that group are doing a lot of really cool stuff, and they lecture on that in Physics 404. So take the class. I really think it's just the conversations with the researchers and that class. And I've worked with some students who are really eager and keen to like do everything they can to make themselves the most competitive. But I think as long as you've identified your passion, and you've made the connections, then it shouldn't be a matter of like, I have to take exactly these classes to get to the place I'm going. I think there are lots of different ways to amass the knowledge base that you need.
That's good to know.
Yeah, and sometimes the knowledge base isn't class-based. I mean, I worked with a student who had leadership experience from managing fire response out of helicopters, right? And that like project management, group management skill is an asset in my discipline. We manage so many teams and projects, and that's not something that you necessarily get out of a calculus class.
Oh, that's really cool. So you don't necessarily have to game the system, which
I don't think
good to
so.
know.
And it's been a minute since I came through, so maybe it has changed. But I do know that we had unfilled positions in our graduate program last year. And we'd made offers, and people were like, later, I'm going somewhere else. So I don't know that it's that we're turning lots of people away at this stage. So I don't have a good sense for how competitive these programs are, but I feel like as long as you know what you want, you're able to communicate it, and you've got like the essential foundation of that physics degree or physics related degree, then it should be straightforward.
That's pretty, yeah.
Mm-hmm. And like the other piece too is that as clinicians, we're so busy and we get 9 million emails a day. And sometimes when a student reaches out, it doesn't make it through the way that we hope that it would. And so sometimes we just need like another little poke.
There you go, you heard it. If you don't get a response to your email, maybe send a second one to follow up. Give some time, but then send a follow-up.
Yeah. Give me at least the weekend.
Oh, that's awesome.
Maybe just if you could talk a bit more about brachytherapy, just for people that wouldn't really even know what that is.
Yeah, I'm sorry. I feel like I've not been repeating your questions, and B, I'm trying not to use too much jargon. Brachytherapy is a style of radiation therapy that's delivered either internally using a radiation or a radioisotope, like a live radiation source, or just like on the surface of the body. So it can be a skin applicator, it could be like an eye plaque. The brachytherapy that I practice is mostly gynecological, so we have applicators that are inserted into the cervix and then around the cervix in the vagina, and we send an iridium source, or an iridium 192 source that is radioactive, into each of the applicators, and we let it hang out for a certain amount of time to deposit dose in a deposition pattern that we like. And it's highly effective for cervical cancer. We've been doing it since essentially the discovery of radium. Since then it has been part of a holistic treatment course for cervical cancer, and it's super effective. Otherwise, I don't think we would do it, because the whole procedure, external beam radiation therapy, is nice because I can take my lunch from my 9-to-5 job, walk into the clinic, I can lay down, they irradiate me, and then I go home, and sometimes I don't even have to take my clothes off. Whereas with brachytherapy, it's like a whole outpatient procedure where the patient comes early in the morning, they're sedated, there's an OR appointment, and et cetera, et cetera. And that is brachytherapy. It's exciting because physics gets to be involved at the time of the procedure in the planning process. So once the applicators are inserted, we'll take a planning CT that we'll put into our treatment planning system. We'll use that to identify the location of the applicators relative to the patient's anatomies. So the disease, of course, and the applicator should be right in the disease, but then also organs at risk, like the bladder or the rectum. And we want to minimize dose to those volumes, because if you over-irradiate those structures, you can cause side effects, or like in really rare and unfortunate cases, like long-term side effects that may impact quality of life. So we don't want to do that. So with the imaging, we're able to quantify the dose that's being delivered in a particular fraction, and then we'll replan it for each of like 3 to 5 fractions to give the healthy tissue time to recover between fractions. And now we're starting to talk about fractionation.
Cool stuff. Where do you see brachytherapy going in the future, if given that it's so invasive?
I mean, like the progress that's been made in terms of miniaturization of sources, so like moving from radium to cobalt then to iridium, so our source has gotten quite small, means that the applicators have gotten smaller as well. And that's been a massive improvement in terms of the invasiveness. I think potentially in the future, there could be a role for very personalized applicators that really fit to a woman's anatomy. In Kelowna, they're using these custom cylinders in place of like a generic applicator, and the cylinder gets placed for like a planning CT, and then holes, like in the process of planning, they plan pathways for needles to travel in the cylinder and then head out into tissue in custom directions in order to achieve a dose distribution that's specific to the woman. And so the applicator is really specific to that anatomy, and it wouldn't be useful for any other patient. And so that's a way, a way in which the techniques are becoming more personalized. I think there are more powerful tools in terms of optimization that might make the planning faster. I think I'm like too underwater to see like any way in which brachytherapy is like really changing a ton. I know there's been some discussion about sort of like intermittently shielded brachytherapy, so a source that could be directional. I've not seen that is super robust yet, or like I think it's very preclinical at this stage, and it's a lot of Monte Carlo simulation of like what if we could. So that could be something that would be useful in a setting where you have an asymmetric volume that you're trying to treat, and the bladder is sitting over here, but at the same distance away from the source, you've got disease, and so you have to decide between, do I like miss the disease or do I overtreat the bladder? So that could be helpful there.
That's cool. Yeah. How much of your time is split between this brachytherapy and the external beam stuff?
I've only talked about high dose rate brachytherapy. There's a whole other team that handles the low dose rate brachytherapy, which are the permanent seed implants for prostate cancer. We treat HDR brachytherapy 3 days a week for cervix, and it typically takes up like half of my day, I would say, if we have a patient. This is really hard to answer because it can change. There are months where brachytherapy is my entire job, but usually it's less than half, because the patient burden with external beam is so much higher than the patient burden with brachytherapy.
Okay, that makes sense.
Mm-hmm.
And what, 7 Linacs? Something crazy?
Oh yeah, we're at, I always have to count, 1, 2, 3, 4, 5, 6, 7, 8, 9. Plus where the cobalt used to be, but the cobalt is being changed out for a rad exact, this helical delivery. Yeah. So 10 really.
Wow.
Yeah.
High throughput.
Mm-hmm. And then it's something like 40 fractions on each unit per day. Like it adds up very quickly.
That's awesome.
But it's also a big team. So we're the largest group of physicists in the province, and there are 22 of us that are checking plans once a week. So
Are there any centers that are just one physicist in charge, or?
So not one physicist, but the group in Prince George is a bit smaller. They're 2 Linacs, and I think they'd like to be 4 or 5 physicists, but right now they're 3. And they get to do a little bit of everything, like I mentioned. They're also like some of the most like cool, competent physicists that I know. So like they got it. But in the US, where the funding models are different, the work-life balance is a little bit different. I do have a friend who works at a 1 Linac center, and he is the only physicist there. And that's a lot to take on, because if you go on vacation, who's putting out fires?
So like the difference between being in Canada and being in the States, like what are the pros and cons, would you say?
Yeah. The difference, I would say that the main difference, from my perspective, all cancer care in Canada is publicly funded. So we're all part of like government healthcare. In the US, you kind of have a 2-style model. So there are academic centers that are often affiliated with a university hospital, and that university hospital is often like a state university hospital or state funded in some way. And so those academic centers are a bit more like the centers in Canada, where you have like the mix of teaching and training and clinical work, and then access to, the extras. In contrast, a lot of the private clinics, especially the smaller private clinics, can be, for example, owned and operated by medical oncologists who are like the chemo oncologists. And they have a radiation therapist because they know that there are some chemo protocols or some cancers that should be treated with radiation, but there's not as much resource or care given to that department, so then they can be run a little bit more threadbare. So you maybe have fewer physicists or fewer planners, and it's like less work-life balancey, I would say. And I don't want to paint every small private clinic that way, because I'm sure there are some like excellent small private clinics, but I've heard some horror stories from some colleagues of mine who've worked in some small private clinics that just like weren't well resourced because it's for profit.
That makes sense. If you don't have enough need for it. Then.
Yeah. And then on the flip side, I mean, we are not for profit, we're government entities. So if I want to buy, I mean, this is an exaggeration, but sometimes it feels like if I would like to buy a pen, I need to go to like public tender and be like, I'm going to buy a pen. Please give me offers on prices of pens. It's not that bad. But it does sometimes feel like we need this technology, and you can't just go and buy it. It has to be a request for proposal process, that it needs to be transparent. And like there are lots of really good reasons for that. Like different strokes, different folks. And not every physicist is the same, like I said. What's nice about the community is that like kind of in a backhanded way, we're all required to be members of our professional organizations in order to maintain our certification. So a requirement of my CCPM certification is that I am a member of the Canadian Organization of Medical Physicists, which is great because it's a great organization and it networks me with all of the physicists across the country, which has been incredible. Like if I needed to know what was going on at Dalhousie, like I could pick up a phone and call somebody right now and find out what's going on in Dalhousie. And then the same thing is true of the American Association of Physicists in Medicine, where in order to maintain your ABR certification, you must be an AAPM member. And then you're networked with every physicist in the country, which is fantastic. And so even if you are the only physicist in a particular center, you still have access to resources and people to have conversations like, hey, I'm thinking about trying this thing. What do you think? What's been your expertise or like your experience in that area, which is very cool.
That's really cool. Yeah, so you have lots of resources and collaborations then. That's awesome.
And since this is like an undergrad directed video, the AAPM also has really great opportunities for summer research for undergrads. So I would recommend looking into that if that's something that you're interested in pursuing. It's called the AAPM Summer Undergraduate Fellowship Research something. And like deadline to apply is often in February. But if you are accepted, then you get a list of really cool projects happening all over North America. And you basically just get to pick which one you do. And they'll throw $6,000 at it and call it a day. And so I think a student membership for the AAPM is very affordable. So it's like worth investing in. I'm not even on the board for AAPM. I don't know why I'm promoting it. Also join COMP.
get involved, see what's out there.
Yeah.
Where do you see yourself, as your career evolves? Where do you see yourself ending up in the future?
Gosh, that's a really interesting question. I think that we ingrain ourselves in like our clinical focuses. I'm pretty heavily focused in the HDR brachytherapy and adaptive right now, in leadership ways. And I think eventually for me, it might look like leadership of a group of physicists at a clinic somewhere, maybe. But that's also very different from getting to do clinical work daily. So it's something that would be a double-edged sword, I think. But hoping to like keep learning new techniques, new technologies. Right now, I'm starting my first term as the Professional Affairs Committee Director for COMP, and that's really exciting, being part of the professional organization. And so I'm hoping that that will continue to grow and evolve. Yeah.
That's really cool. Any other like advice or
I know
tidbits? Maybe some pitfalls that you see people falling into, or maybe you fell into along the way?
I think I already had a spot for making sure that you love your research project, because I did not love my research project going into my PhD, and that was a struggle. But I got through it because at the time, in order to be competitive for a residency, you needed to have a PhD. I don't think that's true anymore, and I would encourage folks to consider, if a PhD isn't their vibe and they're not thinking that they're going to be like researchers, like they're very about being clinical, then probably you're not going to find yourself in a residency at PMH or at BC Cancer Vancouver. But that doesn't mean you won't find yourself in a residency at Lethbridge or Prince George or some other clinic that wants to make you the best clinician that you can be and doesn't require that you're also an academic research scientist.
Oh, that's really cool. Good to know.
Yeah. I think knowing yourself and what you like and what you want to do, and being honest with yourself is really important going into anything. I mean, I don't think that's applicable just to medical physics. I think that's applicable in general. I have found that there have been moments where maybe like I wasn't being honest with myself about what I wanted, and then that sets you up for struggle for like no reason. And then the other thing, I mean, for anyone who's catching this and is about to go into residency interviews, the best piece of advice that I think I can give, and I think was the best advice that like I gave myself, was be yourself in those interviews, because you're going to go into this residency. It's going to be the hardest 2 years of your life, but like in a really good way. But if you have like folded yourself up into a pretzel to fit into a work environment that just like isn't your vibe, that's going to suck. And also like the program will be unhappy and you'll be unhappy and everyone will be unhappy. I think if you come authentic, if you present yourself as you are in like the most positive way you can, then you're going to match with a program that is right for you. And I matched with a program that I didn't think I would match with, and I ended up in San Diego, and it was like the best thing that could have happened for me professionally, I think. And if I had twisted myself to be the pretzel, I may have ended up in a different program, the one I thought that I would end up in. Yeah.
That's cool. That's good to know. I mean, they're the people who are going to be working with you, so they want to know who you
Exactly.
are.
Yeah.
Thank you so much.
Yeah, I mean, I'm happy to like, if you guys have any questions, email me. Like,
Hit me up.
Yeah, I'm always happy to talk about medical physics as a career path, and whether it's right for you. And I love my job and I love talking about
That's awesome. Well, thank you so much for doing
it.
this.
Thank you for having me.
We really appreciated it, and I'm sure people will benefit a lot.
I hope some of it's useful.
All of it.